I'm attorney Richard Hastings. Welcome to another episode of Justice in Scrubs. I'm joined by my co-host,
Dr. Jeff Michaelis.
And we are also joined today by a special guest, Dr. Rick Rosefa, rheumatologist, and we're going to talk about a lot of different issues. Welcome to the show.
Thank you.
Before we dive in, it's important to remember that the information we provide is for informational purposes only. Every situation is unique, and decisions regarding your health or legal matters should be made after consulting with your own doctor or lawyer. Our aim is to inform and empower, but personal circumstances require personalized advice. We'd like to take a moment to thank our sponsor, FindAGreatAttorney.com. If you or a loved one has been injured in an accident, finding the right lawyer can make all the difference in getting the compensation and support you deserve. That's where FindAGreatAttorney.com comes in. They're a free lawyer referral service that connects accident and injury victims with the best attorneys in their area. With FindAGreatAttorney.com, you can be confident that you're getting a highly qualified and experienced lawyer who will fight for your rights. The best part? Their service is completely free. So you have nothing to lose and everything to gain. If you're in need of legal assistance, head over to FindAGreatAttorney.com and let them help you find one of the best lawyers in your area for your case. So why don't we start off and talk about what a rheumatologist is and what the practice of rheumatology involves.
So rheumatology is a subspecialty of internal medicine, and we deal with various diseases of joints and connective tissue, arthritis, rheumatoid arthritis, osteoarthritis, osteoporosis, which we'll be talking about, inflammatory diseases, gout, fibromyalgia, a whole host of diseases that involve the joint and tissues that surround the joint.
So we're going to talk about osteoporosis today. You want to talk a little about what is osteoporosis and what is osteoporosis?
Sure. So osteoporosis has to do with the softening of the bones or the decrease in the density of bones. And this is to some degree a natural consequence of aging and is a very ubiquitous phenomenon in people, particularly women, particularly postmenopausal women. It's estimated that approximately in the U.S., 10 million women have osteoporosis in the postmenopausal stage, and about 43 million may have osteopenia, which is kind of a milder form. And of course, we worry about osteoporosis because of the incidence of fractures that can accrue from having a decreased bone mass.
So some of the risk factors would include aging, of course.
Yes.
And why is it that postmenopausal women are more prone to this disease?
So what happens is when you reach menopause and women lose estrogen, what happens, well, let's look at the structure of the bone for a minute. I don't want to get too far into the weeds, but the bone structure, we have cells that in the bone that build bone called osteoblasts. Those are the good guys. And then we have the cells in the bone that resorb bone, and that's called osteoclasts, the bad guys. So our bones are constantly being remodeled between the osteoblasts and the osteoclasts, and at any given moment, 10% of our skeleton is being remodeled. The issue is that the cells that build bone take months to build bone, whereas the cells that break down bone take weeks. So it's a faster turnover with the cells that break down bone, these so-called osteoclasts. And if there's kind of a coupling between the building and the breakdown of bones, and if the turnover increases, what would happen is that you're going to lose bone over time. And during menopause, when you lose estrogen, the osteoclasts kind of get revved up, and the bone and the loss of bone accelerates. And a woman can lose a large percentage of her bone density in the postmenopausal area. You're sort of, for the first 30 years or so of your life, you're building up your bone density with taking in calcium and exercise. et cetera. But at the time of menopause and there beyond, you have a really rapid loss of your bone density because you've lost estrogen. And that kind of revs up the bad guys in the bone.
Are there other risk factors for osteoporosis, and can men get osteoporosis also?
So interestingly, men can get osteoporosis. We don't talk about it as much. Men do lose bone as they get older, but they don't have that rapid drop-off that women have. But there is a slower decrease of bone density in men as well. And there's certain subpopulations in men that you do worry about osteoporosis. For instance, men who have low testosterone, men who are heavy drinkers, because alcohol can lead to osteoporosis, and men that have been on steroids, prednisone and steroids, can also cause a decrease in bone density through various mechanisms. So for men, you worry about these subpopulations, but they don't have that same rapid drop-off during menopause that a woman would have. So it's not quite the same curve of decrease.
So what are the symptoms and signs of osteoporosis?
So interestingly, osteoporosis is really asymptomatic until you break a bone. That could be your first symptom. And, it depends where you break your bone. Typically, a woman reaches menopause, her risk increases. The first bone she may break in the early postmenopausal period could be a wrist. Maybe she's falling and she'll keep her hands out to break her fall, and she'll experience a Colles fracture or a wrist fracture. And that is a typical early osteoporosis fracture. As the woman ages, she may experience fractures in other areas, such as the vertebral body and the spine, can have a so-called compression fracture. And that may sometimes is without pain, but many times can be a painful situation for several weeks. And a woman may actually lose height as a result of compression fractures in the spine, or actually develop what's called a dowager's hump, kind of a hunchback with the repeated fractures in the lumbar spine. And then perhaps later on, you can have the most serious fracture, which is the hip fracture. The hip fracture, which can result from a fall, sometimes minimal trauma. A hip fracture carries with it a high morbidity and actually even a mortality. There's estimated between 20 and 30% of hip fractures will result in mortality from either pulmonary emboli, or pneumonia, or other factors that can result from being immobilized from a hip fracture. So that's the most serious fracture. And when we look at fracture risk, we take into account we haven't gotten into this yet, but we can measure bone density, and we take into account the density of the hip as one of the major drivers in determining whether to treat or not.
So you want to talk about how, what testing we should do to maybe prevent these fractures, or who should get tested and how do you get tested, that kind of thing?
Yeah, excellent question. I feel that all women, once they reach menopause, should be tested for osteoporosis, and sometimes if there's a high index of suspicion, even before menopause, but certainly all women at menopause should be tested. And the treatment, the imaging that is done is called a DEXA, a dual energy X-ray absorptiometry test, although there are other tests, but that's the most commonly used. And what that does is we look at various areas of the body, particularly the spine and the hip, where we're worried about fracture. And some DEXA machines will also look at the distal radius in the wrist. And you can actually assign a value to your bone density. And what you're basically doing is you're looking at one's bone density and you're comparing it to a cohort of 30-year-old women. Now, that's not fair. If you're a 70-year-old woman, comparing it to 30-year-old women, that's how it is. And so what we look at is what is your bone density compared to a cohort of 30-year-olds, and we look at the standard deviations below that. So if you're one standard deviation below that cohort of 30-year-old women, you have it's called a T-score of minus 1.0. Or more, depending on how low your density is. By convention, if a T-score is minus 1 to minus 2.5 in that range, it's called osteopenia. And if the T-score is below minus 2.5, it's called osteoporosis. So there's a strict definition of osteoporosis. And you can measure a T-score in the lumbar spine, you can measure a T-score in the hip, you can measure it in the wrist. So I feel all women at that stage should be tested, and to see if, in fact, they are osteopenic or osteoporotic or normal. Interestingly, most women who fracture, and actually, interesting statistic, 50% of all postmenopausal women will experience a fracture at some point in their lives.
Wow.
50%. And most of those fractures come from the osteopenic section because they're so much more common than osteoporosis. So having osteopenia, even though it's a milder form, still we have to take seriously, and depending on other risk factors, which I can talk about, you might want to treat someone with osteopenia as well as osteoporosis.
So why don't we talk about the risk factors?
Sure. So since we mentioned the menopause, the age of menopause makes a difference. If you have menopause in your early 30s versus, let's say, 50s, you have that many more years of lack of estrogen and that many more years of losing bone density. So early menopause is one factor. Family history is another factor. Particularly if either of your parents sustained, let's say, a hip fracture, that puts you at greater risk. Asian and Caucasian women versus African American women tend to have lower bone densities and at a greater risk. Being exposed to certain medications, such as steroids, which we mentioned briefly, but also some ulcer medications called proton pump inhibitors. High-dose statins can also increase risk of osteoporosis. Having had a fracture puts you at greater risk of a second fracture. The statistic that I see commonly is that if you have a fracture, a fragility fracture, and what we mean by fragility fracture is a fracture that doesn't take a whole lot of trauma to occur. Let's say if you're sitting or standing and you fall and you break your wrist, that's a fragility fracture as opposed to falling out of a building. You know, anyone's going to break a bone if you fall out of a building, but if you're standing or sitting and you fall and break your hip or break your wrist, that's called a fragility fracture. So having a fracture, over the next 2 years, your likelihood of having a second fracture is over 10%. And that's a population you really want to identify because they may be certainly a candidate for treatment. Let's see.
Sedentary lifestyle?
Well, yes. Exercise, extremely important, particularly weight-bearing exercise. Weight-bearing, anything involving gravity, will stimulate those osteoblasts, the good guys in the cells. And sedentary lifestyle can certainly help to accelerate osteoporosis. Also, not taking in enough calcium, either through diet or supplement, and also vitamin D deficiency. Vitamin D is extremely important in osteoporosis. Vitamin D helps to absorb calcium, also helps for neuromuscular function. So anyone who's being evaluated for osteoporosis, you really have to make sure that their vitamin D level is optimal. And vitamin D deficiency is ubiquitous. I think about 40% of my patients, when they see me, have vitamin D deficiency, and certainly that's something that one can correct.
What about diet, smoking, excessive alcohol use, obesity? We wanted to take a quick break to remind you about our sponsor, findagreatattorney.com. Dealing with the aftermath of an accident or injury can be overwhelming. And the last thing you want to worry about is finding the right lawyer. Findagreatattorney.com simplifies the process by connecting you with one of the top attorneys in your area who specializes in your specific type of case. Whether you've been injured in a car accident, suffered a slip and fall, or experienced medical malpractice, findagreatattorney.com has a network of experienced lawyers ready to help. And remember, their service is completely free, so you can focus on your recovery without worrying about the cost of legal representation. If you or someone you know needs legal assistance, don't hesitate to visit findagreatattorney.com and let them match you with one of the best lawyers in your area for your needs.
Yeah, so smoking and alcohol are both risk factors. And obesity, interestingly, can be protective. If you fall, you have more cushion, so to speak. So that's just one example where being thin which is great to be thin for every other reason, but being thin when it comes to osteoporosis is a risk factor. Thin, Asian, Caucasian phenotype can increase one's risk of fracture and osteoporosis. When we look at these measures with the bone density, we're looking at the T-score, and we're making an assumption, and I think it's a good assumption, that your decreased bone density correlates with your increased risk of fracture. And studies that look at various medications, which we can talk about, some of them look at the ability of a medication to increase bone density, and some of them look at the ability to decrease fracture. And we're kind of making an assumption, but there does seem to be a correlation between the higher the bone density, the less likelihood of fracture.
So anybody who has a fracture should get and they're over the age of something, 50, 60, they should get a bone density, or only if they get a fragility fracture?
That's a good question, and sometimes it's a judgment call about whether it's truly a fragility fracture or not. But I think, first of all, anyone should get a bone density if they're postmenopause. But if they have a fracture, I think they haven't had a bone density, they certainly need one. Interestingly, patients that present with fractures in this country, in the 21st century, very few end up being evaluated for osteoporosis, even in this day and age, with all that we know about it. Very few. I think about 10 to 15%, which is crazy. And that number is actually going down, not going up. So they worry about the fracture, they treat the acute fracture, but then the long-term treatment of the perhaps underlying osteoporosis or osteopenia is often being neglected. That's something that really has to be corrected.
So you want to start talking about treatment?
Sure. So, when I was a fellow during the Roosevelt administration.
Which one?
Teddy Roosevelt. Teddy Roosevelt.
You look very good.
Thank you. We didn't have treatment for osteoporosis. Osteoporosis was a disease of prevention. We had nothing to treat it with. And then I started my career here in Connecticut, and I remember getting a consult from a doctor, an orthopedic doctor, for evaluating a patient for osteoporosis. And I was thinking, I can't do anything. They have osteoporosis. You can't. But in the mid-'90s, we had our first treatment for osteoporosis, alendronate, also known as Fosamax, which, just stepping back a little bit, we talked about the good guys and the bad guys in the bone. The treatments for osteoporosis are broken down into one of two categories. Number one are the medications that inhibit the osteoclasts, they decrease the resorption. That's category number one. Category number two are the anabolics, the drugs that enhance the ability of the osteoblast to make more bone. So you either inhibit resorption or you promote the building of bone. So Fosamax or alendronate, which was the first medication, was an inhibitor of the osteoclast. And this was a breakthrough. Now we could finally treat osteoporosis. And it was soon followed by several other, and this is a pill, oral so-called bisphosphonates. Alendronate was the first one. Then we had Actonel, we had Boniva, and then we had probably the best one of all in that family was a medication called Reclast, which is an intravenous infusion once a year. And these medications all basically do the same thing. They inhibit the osteoclast, and therefore you can see some increase in bone density over time. The problem with these medications is that they don't work indefinitely, and over time their benefit kind of plateaus, and there could be greater risk of side effects. There's a relatively rare side effect of osteonecrosis of the jaw. You have like death of bone cells in the jaw, which you can see with these medications. And even there have been some instances of idiosyncratically atypical fractures from being on these medications for a long period of time. So anyone on these medications, the bisphosphonates, you have to, and it's somewhat controversial how long to keep them on before you have to stop or give them a drug holiday. I generally speaking don't go more than 5 years with these medications without some kind of break. Now, some of them may have to go into some other things. We have other options too. And some of them can go on a holiday for a few years. The next...
Can we just have one question?
Sure.
Someone who goes on Fosamax, should they tell their dentist that they're on these medications?
So they probably should. The dentists tell me about, they see more than I have seen, this osteonecrosis of the jaw. In my long career, I don't remember even seeing a single case, although dentists tell me they will occasionally see a patient with on a bisphosphonate who might have this complication. So I think if somebody is about to have dental work done, extractions, et cetera, you probably wouldn't start that medication at that time. But really, it's a pretty low incidence. So 1 to 10,000, 1 to 100,000 will have this particular complication.
But you've never seen it?
I personally have never seen it.
And you've been working since the Teddy Roosevelt
Pretty much,
era,
yes,
so
yes. Teddy Roosevelt,
It's been
yes,
a little
yes,
while
yes,
since you've been
yes,
working.
Yes, I've not seen it myself.
But
it's been described, and it does happen.
That's very encouraging
common, yes.
that you haven't seen it. Yeah.
Yeah.
Okay, why don't you go on to the next set of treatments?
So in that same family of the anti-resorptives, you have a medication called Prolia. Prolia is a shot every 6 months. It's been around for probably maybe 15 to 20 years now. Extremely well tolerated and also works in the same fashion. Now, unlike the bisphosphonates, Prolia, you have to stay on indefinitely. Or let's put it this way, you can't stop it and do nothing, because there have been cases, I'll give you an example. I had a patient who was on Prolia for several years doing very well, and then she was lost to follow-up. I don't remember what happened, whether she moved or she stopped seeing me for whatever reason. And so she missed her Prolia. It was time for her Prolia, the 6-month point. She missed it. She was several months late, and she ended up having several compression fractures in her lumbar spine.
Wow.
Because of this so-called rebound phenomenon. If you stop Prolia, you could have a rebound where you lose all your gains and actually have gone on to have fractures. So it's very important on Prolia to stay with it, or if you stop it, to go on something else, usually another a bisphosphonate.
Just missing 2 months can make such a difference.
In her case, yes, they say that within 6 months of being overdue, you'll lose all your gains. She lost it quicker than that.
Wow.
And there are ways to measure bone turnover. But the important point is that you have to take Prolia very seriously. It's a great drug, and it's in all my experiences with these medications, it's probably the one that's best tolerated. I almost never see side effects with Prolia, but you really have to be on the lookout, making sure the patients come in every 6 months and stay with it, and perhaps lifelong.
And it's just a sub-Q injection,
Subcutaneous injection. Very easy. We do it in the office.
And you do it right in the office?
Do it right in the office, and it works very well. We see patients who can gain bone. At the very least, they don't lose bone. They can gain bone on Prolia, and it just seems to keep on working. We have data up to 10 years on Prolia, and I'm sure, as time goes on, we'll have even longer-term data. So,
yeah, and are there side effects of Prolia?
So you have to make sure that you can have cases of low calcium. You have to make sure, that it works pretty well with patients who have renal insufficiency. The jaw osteonecrosis that I mentioned with the others, you can see with Prolia, but again, very, very rarely. But the vast majority of patients have no trouble whatsoever in Prolia.
Have you seen any bad complications in your
I saw a couple in my 95 years of practice, a couple of side effects here and there. I had that one patient who had the rebound compression fractures because she didn't take it. I have seen a few non-serious things here and there, for which I had to stop it and do something else.
Have you seen any of these atypical fractures that they talk about?
So for the bisphosphonates, I did have 1 or 2 patients who had atypical femoral fractures from bisphosphonate use. Yeah, but that's my denominator is pretty large, but I did see a couple of those cases. Yeah.
Why don't I ask you if you could jump out of the medical, taking pharmaceuticals, for example, are there any things that we can be eating or doing or adjusting in our life that can make our bones stronger without the need to take medicines?
So calcium is extremely important. And for, let's say, the average postmenopausal female, you want 1,200 milligrams of calcium a day. Now, that's a lot of dietary calcium. And there are some advantages of dietary calcium over a calcium supplement. Dietary calcium doesn't seem to have the same risk of kidney stones. It's perhaps more bioavailable. And I always encourage patients to get as much dietary calcium as they can so they don't have to take as much of a calcium supplement to make that 1,200 milligrams. So calcium is extremely important. Vitamin D, I touched upon, exceedingly important because vitamin D helps you to absorb the calcium and does 10 other good things for the body. So vitamin D, we get vitamin D from the sun and some foods, and of course there are supplements. But my dermatology colleagues caution me that you're not supposed to tell patients to be out in the sun without sunscreen. So they need sunscreen, but of course sunscreen blocks vitamin D. So you try to have a little bit of a balance. I tell patients 15 to 20 minutes in the sun without sunscreen to get your vitamin D, and then make sure you put sunscreen on if you're going to stay in the sun to protect your skin.
So one of the things that I do in my diet is I don't drink milk. So I drink almond milk. I don't drink cow milk. I drink almond milk. But
Yes.
I just heard recently that almond milk is not very good for you because it depletes certain things from your body. Do you know anything about?
I'm not aware of that. I know the almond milk has calcium. Yogurt is a great source of calcium as well. Cheese. So you can get it from other sources besides regular milk. And by the way, skim milk has just as much calcium or more than whole milk. So and probably healthier.
Are there like liver or things like that you can eat that adds to that?
A little bit. Vegetables, fish has some, but some, perhaps not as much as the dairy products.
And it's, I guess, more important for postmenopausal women to be taking these calcium supplements than it would be for an older male. Is that correct?
Well, I think calcium's important for everyone. And as we said, women seem to lose bone density quicker than men, but men do lose it over time also. And when you get to be, an old gentleman, your chance of osteoporosis, is not negligible either. We don't always remember or think about it in men, but it certainly does occur in men, and it would not be unheard of in certain situations where you have a higher index of suspicion to have a man have a bone density.
So what about the patients that are lactose intolerant and they really can't handle dairy? What do you tell them about the calcium intake?
So if they can get it through other foods, and I give them a handout that shows how much calcium is in everyday foods, and if they can't get enough in the diet, then you have the supplements.
So, but if they take the lactose pills for lactose, and if they take the lactase pills for lactose intolerance, do they still get the calcium from that?
From the lactase?
If they take the lactase pills to be able to take dairy products in,
right,
they still will get the calcium.
Oh yeah, they'll still get it from the foods that they are taking.
That.
Yes,
Yeah.
Sure.
Okay. Do you want to talk about the newer medications that are coming out? Yeah.
So there are some ones that are no longer so new, but they're the so-called anabolics, the ones that build bone. These are the stronger medications, and there are two anabolics that have been around. The first one is called Forteo, which is an injection once a day for 2 years. Many people don't like that concept, but that's the only form it's in now. So for 2 years, you give yourself one shot a day, and it's an anabolic. It will actually build bone, and you'll see the bone densities go up significantly over time, and hence the fracture risks go down. And a newer medication, which is probably even stronger, is called Tymlos, which is a once-a-day injection for 18 months. So it's a little bit shorter. And these medications can work very well. They're basically analogs of parathyroid hormone. What's interesting is parathyroid or hyperparathyroidism, which is an endocrinologic disorder of the parathyroid gland, depletes the bones of calcium. And back in the Roosevelt administration, when I was a fellow, there was a doctor, Robert Neer, in the endocrinology department, who found that continuous high exposure to parathyroid hormone can result in osteoporosis, but intermittent low dose of PTH analog can actually build up bone. And this was so crazy, this thought was crazy, but meanwhile, these two drugs came as a result of that research, and they're great drugs for osteoporosis because they actually build bone. And they've been around, well, Tymlos has been around for almost 10 years, Forteo probably 20 years. And there's some patient pushback because they don't want to give themselves a shot every day. But if they're able to do that, it can work very, very well. So patients who are very high risk, I would certainly suggest this. And then the newest one on the market actually has a dual mechanism. It not only builds bone, but it inhibits the breakdown of bone, and that's called Evinity, which is 2 shots at the same time once a month for a year. And Evinity, there's a protein called sclerostin, which is a really bad actor in bones. It it inhibits the osteoblasts and it enhances the osteoclasts. And this Avidity is a antibody that blocks sclerostin. So patients are able to build bone and have an inhibition of the breakdown at the same time. So Avidity is a dual mechanism and probably has the greatest data in terms of building bone density over time. It's new. It's been around for about just before the pandemic, so maybe 5 years. But it seems to be quite safe, and it's just for 1 year, and it's tolerable to have 2 shots a month, and patients seem to be more accepting of that.
Is it a pen or is it the old-fashioned syringe?
Old-fashioned syringe, yeah. But we do it in the office. They don't.
You do it in the office?
Yeah, we do it, yeah.
Oh, they don't do it themselves?
No.
But the Forteo, they do themselves?
Yes. Well, theoretically, they don't want to come in every day. So, yes. And it comes in a pen, so they may not, the Forteo.
Yeah.
And the pen will last, let's say, for a month. Then they get another pen for the next month. But, it's getting them over that concept of giving themselves a shot every day. But it's not as bad as they probably think about. It's in their mind. But that concept is tough to overcome in some people.
So did you have any other questions about that subject? Because I wanted to kind of jump into arthritis for a little bit.
Go ahead.
So, this is a topic that is really near and dear to my heart. Well, not dear, but my mother died of complications involving RA, rheumatoid arthritis. And it was an insidious disease that completely destroyed her joints in her hands and her elbow and her knees. And I wonder if we could talk about the different types of arthritis that people suffer with.
So the most common type is called osteoarthritis, the wear and tear arthritis that everybody gets somewhere at some point in their lives, worse with age, can happen after trauma, can occur in various joints, and that's a non-inflammatory arthritis. And even though it's the most common, and we deal with it every day, we don't have a treatment that can prevent it from getting worse. We have joint replacement surgery, we have treatment for pain, we can give injections, but we don't have that magic bullet that can actually affect the course over time of osteoarthritis. They're working on it, and there are some potential candidates for that, but we don't have that answer. Rheumatoid arthritis, which your mother had, less common, but that's an inflammatory arthritis, which can go on and cause deformities, morbidities, and mortality, and can be very symptomatic. But the good news is that we have great treatments for rheumatoid arthritis. I'm not sure how long ago your mother was diagnosed, but we have...
Probably 45 years ago.
Yes.
In fact, one of the things they did for her was they injected gold into her, and she said that the side effects from the gold injection were worse than the arthritis.
Yes, interesting. Gold, and I'm old enough to remember gold, barely, but old enough to remember gold. So the thing about gold was it would work a third of the time, it would not work a third of the time, and it would cause side effects a third of the time. And there was even an oral gold that came out in probably the 1980s. But since the late 90s and the turn of the 21st century, we have these biologic agents, which are revolutionary and relatively safe, which can really stop rheumatoid arthritis dead in its tracks. And what we know is that making a diagnosis early before chronic changes occur in the joint, we can prevent patients with RA from ever having deformities, and they can live a normal life. So unfortunately, your mother missed that because of the timing.
Right.
But patients now who are diagnosed with RA certainly don't have to suffer that way because of what we have out there. And we have many, many options for these patients. So
let me just jump back a second to osteoarthritis. So when I represent people who have been in some type of an accident and they have open reduction internal fixation surgery, they're told by their doctors that your risk of developing arthritis are greatly increased. Why is that?
So if you injure a joint, there have been well-documented acceleration of osteoarthritis in that joint over time. Interestingly, I hope I don't get my orthopedic friends in trouble, but you know about these arthroscopic surgeries in knees for meniscal tears. That was done very, very commonly a few years ago, and it was found that as a quote trauma would increase the incidence of knee osteoarthritis over time. And so a typical scenario would be 1 year the patient gets the arthroscopic surgery in the knee, and a few years down the road they need knee replacement because the arthritis got so much worse. So any damage to a joint, whether it's surgical or traumatic, can result in osteoarthritis in that joint. So it's a very common scenario.
Why don't we talk about gout you had mentioned earlier? What is gout and what can you do for it?
So gout is an elevation of uric acid. And why does someone have an elevated uric acid in the body? Usually it's because they're not able to excrete it adequately. So gout is actually a kidney disease. It's a failure of the kidney to excrete uric acid. So that uric acid builds up in the blood. So you have a high uric acid. And if the uric acid gets to a certain level, it can precipitate and crystallize in joints and causing acute arthritis. Typically, it's in the big toe where it starts, but it can really be in any joint, usually in the lower extremities, but it can be in any joint. Gout is extremely treatable. And the key to gout is to lower the uric acid. And patients ask me all the time, well, what do I do in my diet to lower the uric acid? And there's certain foods that you avoid, fatty red meats, shellfish, alcohol. But if you have an assiduous diet for gout, you might be able to lower your uric acid by 1 point. And that's not a lot. But medication can do very, very well in lowering uric acid. And if you lower uric acid, eventually those attacks will go away. If you don't lower the uric acid, you're going to go on and have more attacks involving more joints, and it can become very, very serious and debilitating. But the good news is that gout is extremely treatable. And it's one of my favorite things to treat because I know I can cure it, basically. And again, like anything else, you hope you can get to a patient earlier rather than later on.
What about psoriatic arthritis?
So psoriatic arthritis is arthritis associated with psoriasis. It usually occurs after the diagnosis of psoriasis. Sometimes it occurs before the diagnosis of psoriasis, which makes the diagnosis difficult. And it can take various forms. It can look like rheumatoid arthritis in terms of the pattern of joint involvement. It can involve the axial skeleton. It can involve a joint here and there. So it has different patterns. And like rheumatoid arthritis, it's an inflammatory arthritis and has extremely great medications, which help not only the arthritis, but the skin as well. And again, we have a lot of options for patients, and there are more things coming on the market all the time. So there are 12 things we can do for a patient with psoriatic arthritis so that they don't have to suffer either the skin issues or the joint problems. So.
And I think it involves rheumatology, but it also involves so many other areas of our health that when we have inflammation within our body, it causes major health challenges, or can. So are there foods that cause inflammation, or are there things that we do that cause inflammation, or what are those things that we have to look out for?
Yeah, so you've heard of course the Mediterranean diet, the anti-inflammatory diet. Many years ago, going back to my fellowship, I did work on prostaglandins and fish oil, which is an anti-inflammatory. So keeping to avoiding high carbohydrates, high sugars, keeping to a Mediterranean anti-inflammatory diet can be helpful. And it's interesting circling back to osteoporosis. As people get older, the inflammatory mediators in the system can increase. And inflammatory mediators can actually drive osteoporosis. So one of the areas of research, going back to osteoporosis for a minute, is looking at inhibiting these interleukins and other inflammatory pathways that can actually not only drive inflammation, but can lead to osteoporosis. And one area of research is treatments that we use for RA, some of them might actually be helpful in osteoporosis as well, because they'll decrease inflammation. Looking at the other way, going back to Prolia just for a second, there is some evidence that Prolia not only does great things for osteoporosis, but may also be disease-modifying in osteoarthritis, which is unheard of. But there's a small study or two that look at patients with osteoarthritis of the hands. Going on Prolia, there have been some instances of a delay in progression of osteoarthritis. So Prolia may hold a key to osteoarthritis too, possibly. It's very preliminary, but very interesting. So there may be some dual uses for a lot of these medications, not only in osteoporosis, but also in various forms of arthritis. So
and we've talked about this on multiple episodes of ours about things that have a greatly adverse effect upon your health, and they are things like a poor diet, a sedentary lifestyle, over drinking, smoking, these things that, it would apply to this situation as well.
Absolutely. Yeah, sure.
Okay, so you want to go back a little bit to the osteoporosis. Let's say I'm a 59-year-old female.
You don't look like one.
Yeah, thank God. And I fracture my wrist.
Okay.
I was on one step stool, one step, and I fell down and I fractured my wrist.
Okay.
So it's sort of in between whether it's a fragility fracture, or a real fracture.
Yeah.
What would you do? And you were seen by the primary care doctor who took care of the wrist, and now they're referring the patient to you.
So one thing I didn't talk about was when I do, and I would definitely do a bone density if you hadn't had one, but I do what's called a fracture risk assessment, which takes into account the numbers, also your height, weight, and age, and also your risk factors. And you plug it into a formula, and I can predict your risk of fracture over the next 10 years by this fracture risk assessment. And from that, I would probably make a decision about whether to treat you or not.
So what's in the fracture?
Fracture risk is FRAX, F-R-A-X. It's been used for quite some time now, and it's a formula that takes into account the numbers on your bone density, your height, weight, age, gender, and such things as whether there's a family history, did your mother or father break their hip, how old were you at menopause, have you been on prednisone, do you have hyperparathyroidism, hyperthyroidism, what else? Are you a smoker? Are you a drinker? They take all these risk factors into account, put them all together, and we can estimate your risk of fracture. And I can say over the next 10 years, your risk of breaking a bone is 25%, which is pretty high. And from those numbers, I can suggest that we treat or not. But the fact that you have an acute fracture in your wrist in and of itself does increase your chances of getting a second fracture. So,
is there a lot of pushback? I know there's some media attention to these medications, and some people don't want to take these medications because of that. Can you talk about that?
Just this morning, I saw a very lovely woman who has her risk factor basically is the fact that she's Caucasian and thin, but she does everything right. And unfortunately, she has osteoporosis in the hip and spine. And we talked about it, and I did the FRAX analysis on her, and she should be treated. And she's extremely educated and intelligent, and we discussed it. And she doesn't want treatment. And of course, she knows what the risks are. I gave her the numbers, and so for her, we're going to go along with what she wants. My preference would be to treat her. She doesn't want to be treated. So we're going to do everything right from lifestyle point of view. She'll take calcium, she'll take vitamin D, she'll exercise, and we'll probably do a follow-up study in 2 years, hoping that she's maintaining. But if she isn't, then we may have to have this discussion again. And I told her, look, you've never fractured, which is great, but if you have a fracture, I'm going to push harder because that's going to put you at a higher level of risk. But not infrequently, I see patients who come in and they don't want to be treated because they know about the potential side effects. And all I can do is make a recommendation. If they don't want to do it, then we work with them anyway. So,
what are they most worried about? They worried about the stomach. They worried about their teeth. They worried about their atypical fractures. What are they most worried about?
So the jaw osteonecrosis gets a bigger play than what I see. And patients tell me about that all the time. For Prolia, that's the one that you're on constantly. They don't want to be on something forever. I can understand that, even though it's once every 6 months. They do focus on the side effects because, of course, if they do reading, they read about all the side effects without the context of how frequently they are. And I can understand that. So we work with them, and if the risk was very, very high, I would push harder. But all I can do is suggest.
What about the stomach side effects for Fosamax and those type of medications?
So the oral medications do have an instance of heartburn, reflux, occasional ulcer. That's pretty much obviated with the Reclast, which is the IV form of the bisphosphonates. That has another side effect, which is in a small percentage of patients with Reclast, they can develop aches and pains afterwards, a small percent. And also you have to be very careful with their kidneys before you give them a reclassed infusion. But it does obviate the GI effect.
So reclass is once a year, right?
Yes.
How long does this pain last after an injection? Does it last a whole year? Or
No. And they ask me that all the time. So we actually track this. It was about 13% of our patients will have that side effect after reclass. And what we tell them is drink a lot of water 24 hours before, take Tylenol before, and that minimizes that. When they get the pain, I think the most I've had a patient for about 10 days. That was the most. If it happens, again, in that small percentage, 2 to 3 days of aches and pains afterwards. By the way, you can see that with the orals also in a small percent.
So if they get the pain, does Tylenol alleviate it, or do they need something stronger?
No, I don't remember ever having to give a patient a prescription of pain medication for that.
And you've been doing this a long time. So.
I've been doing it more years than I like to admit. Yes,
so
right.
I have a question about your practice. Is your practice 100% referral based? That is, somebody just doesn't pick up a phone and say, hey, I think I'm going to see a rheumatologist. They go to their GP or their PCP and then they're referred to you, or they go to an ortho and then they're referred to you?
We have some self-refer, but most do come from another physician, yeah.
What's the best part of your job?
Leaving to do a podcast.
Great answer.
That is a good answer.
There's certain things. I love treating osteoporosis because, in general, the patients are motivated, intelligent. They want to treat this proactively, and they're my favorite patients. So that's a good part of my job, I think, because I remember a time when there's nothing I could do, and now I can do a lot. And the same thing with RA, rheumatoid arthritis. There's so many things we could do now that we couldn't do 25 years ago. So.
And my mother back in the day had taken prednisone for decades, and she got to the point where she had tissue paper thin skin where they couldn't perform surgery on her at the end because they couldn't sew her up. And thank God that things progressed to the point where there are newer and better medicines that can take care of these things.
Right, absolutely. It's funny. I tell people I spend half my job trying to get patients off prednisone and half my job doing everything else. The whole thing is to find substitutes for prednisone.
Well, you've provided us with a lot of great information today. Our viewing public, gets bits and pieces of what we talk about. Some of them are really tuned into this stuff because it affects them personally. But we want to thank you for coming on the show and giving a lot of great information today.
My pleasure. I appreciate it.
Thanks.
Thank you.
Thank you very much.
Thank you.